The GINA report, that is Global Initiative for Asthma report, has been updated in 2022 following the routine twice yearly review by the scientific committee. I have discussed the key changes here in this video. I would also suggest the viewers who are viewing this video for the first time to go through the previous videos on earlier GINA guidelines, especially the earliest one, 2019 one, to have a preliminary understanding. To recapitulate the previous GINA guidelines, the links of which I have shared in the description box below, the concept of reliever therapy with SABA alone, that is short-acting beta agonist alone, is no longer recommended, especially in adolescents more than equal to 12 years of age. Rather, either during exacerbations, as in steps 1 to 2 of the GINA treatment track, or daily, as in steps 3 to 5, therapy with ICS, that is inhaled corticosteroid, and formoterol, which is a long-acting beta agonist, the combination of ICS formoterol should be done. Examples of this combination available in India are Foracort by Cipla, Butamate by Lupin, and Symbicort by AstraZeneca. So as per the GINA 2022, the diagnostic testing is different depending on whether the patient is already on controller treatment or not. That is, if the patient is being diagnosed for the first time or is already taking controller treatment. For example, in case the patient has variable respiratory symptoms but the airflow limitation is not variable, then in that case we can confirm the diagnosis by considering a repeat spirometry after withholding the bronchodilators. The time specified is 4 hours for short-acting beta agonists, 24 hours for twice daily inhaled corticosteroids long-acting beta agonist combination, and 36 hours for once daily ICS LABA or during symptoms. And then check the between visit variability of FEV1 and the bronchodilator responsiveness. If FEV1 is more than 70% of the predicted, then we must consider stepping down the controller treatment and reassess in 2 to 4 weeks. However, if the FEV1 is less than 70% of predicted, we may consider stepping up the controller treatment for 3 months and then reassess symptoms and lung functions. If, however, there is no response, then we may resume the previous treatment and refer the patient for diagnosis and investigation. Now, the majority of the burden of asthma morbidity and mortality, as we all know, is experienced in low and middle income countries, and most of this burden is avoidable. So in GINA 2022, additional details have been included about diagnosis and management of asthma in these settings, where the differential diagnosis often includes endemic respiratory diseases and infections also, for example tuberculosis and HIV/AIDS. So in these scenarios, in these resource limited settings, that is low and middle income countries, when spirometry is not available, the presence of variable expiratory airflow limitation can be confirmed by peak expiratory flow. Rather, GINA 2022 suggests that improvement in symptoms and peak expiratory flow after a 4-week therapeutic trial with anti-inflammatory therapy with a 1-week course of oral corticosteroids if necessary can help to confirm the diagnosis of asthma or prompt an alternative diagnosis if that is not there, before starting the long-term controller treatment in these patients. As discussed in detail in the video on GINA Guidelines 2019, if we wish to assess the symptom control in a patient of asthma, then we need to ask 4 questions in the past 4 weeks, whether the patient has had daytime symptoms more than or less than 2 times per week, any night awakening due to asthma, reliever medications required more than or less than 2 times per week, and any activity limitation due to asthma. So if the answer to 3 or 4 of these questions is yes, then in that case we say that the patient's asthma is uncontrolled. If the answer is yes to 1 to 2, then it is partially controlled, and if the answer is yes to none of these questions, then the asthma of the patient is well controlled. So GINA 2022 prefers excluding the criterion of using ICS formoterol more than 2 or less than equal to 2 times per week from the assessment of symptom control. Actually, the frequency of SABA reliever use, whether less than or more than equal to 2 times per week, had been included in the composite assessment of symptom control based on the assumption that if SABA was used on more than 2 days in a week, the patient had to be started on controller therapy or increase the dose. But now with the use of ICS formoterol as reliever, if the patient is taking ICS formoterol on an average of more than 2 days per week, then this is already providing additional controller therapy, so dose escalation will not be required. Also, increasing use of as needed ICS formoterol is associated with a significantly lower risk of severe exacerbations in subsequent days or weeks compared with if the reliever is SABA. That is why the GINA is keen on excluding this criterion from the assessment of symptom control. But as the GINA is gathering further evidence in this regard, it continues to say that the average frequency of use should still be considered while making decisions of the treatment. The current definition of asthma severity is based on the concept of difficulty to treat. That is, severe asthma is defined as asthma which remains uncontrolled despite optimized treatment with high-dose inhaled corticosteroids, long-acting beta agonists, or that which requires high-dose ICS-LABA to prevent it from becoming uncontrolled. Moderate asthma is well controlled with step 3 or step 4 treatment, for example low or medium dose ICS-LABA in either treatment track, which we'll see in a further subsequent diagram. And mild asthma is well controlled with as needed ICS formoterol or with low dose inhaled corticosteroids plus as needed short acting beta agonists. So currently the GINA 2022 suggests that the term mild asthma should generally be avoided in clinical practice wherever possible. But if at all it is used, it should be used with a reminder about the risks of severe exacerbations even in mild asthma and the definite need of regular ICS containing treatment. For treatment of adults and adolescents, antithymic stromal lymphopoietin, that is anti-TSLP, the drug name is tezepelumab, has been added as a new biological therapy for severe asthma in step 5, as you can see in this figure. The first one, the controller and the preferred reliever, is the track 1, and second one, the controller and alternative reliever, is the track 2, which I had been talking and have discussed in detail in the earlier earlier videos on GINA guidelines. Also, for treatment of children between 6 to 11 years, anti-interleukin 4, that is dupilumab, the drug is called as, has been added to step 5 options in severe eosinophilic and type 2 asthma, as you can see in this diagram. Now someone would ask the question, what is type 2 asthma? So here I would like to clarify that asthma is of two types, type 2 and non-type 2. Type 2 is characterized by typical type 2 inflammation, and the examples are allergic asthma, exercise-induced asthma, and E-asthma, that is eosinophilic asthma. Whereas non-type 2 asthma is non-eosinophilic and neutrophilic asthma. Why we need to differentiate between these two types of asthma is that the non-type 2 asthma does not respond well to inhaled corticosteroids, and we might have to consider other therapies for these patients. Also, it has come up with certain other recommendations like long-acting muscarinic antagonists, for example aclidinium, glycopyrronium and tiotropium. I must tell you that LAMAs, that is long-acting muscarinic antagonists, have traditionally been used in the treatment of chronic obstructive pulmonary disease. So GINA 2022 suggests that LAMAs should not be used as monotherapy, that is without inhaled corticosteroids, because there is a risk of severe exacerbations in patients receiving LAMA without any inhaled corticosteroids. Adding LAMA to LABA that is long-acting beta agonist, has no clinically important benefits for symptoms or for quality of life, and the evidence by GINA 2022 does not support the same in adolescent and adult patients with exacerbations despite inhaled corticosteroids LABA. Rather, what it says is that you must increase the dose of ICS LABA. Like here I would again like to clarify, the reliever which has been stressed upon by GINA in the guidelines in the near future and even in GINA 2022 is low dose ICS and LABA, low dose ICS formoterol combination. So if the patient is not responding to this, then you need not add LAMA. You must first consider stepping up the dose of inhaled corticosteroids to medium or high dose, and Only after that you may consider adding LAMA. For patients with difficult to treat asthma and blood eosinophil counts more than 300 per microliter, one must investigate for non-asthma causes, including the testing for strongyloids, before considering biological therapy with monoclonal antibodies, since strongyloids infection is often asymptomatic. And for patients with hypereosinophilia, that is blood eosinophils more than 1500 per microliter, one must rule out causes such as eosinophilic granulomatosis with polyangiitis, that is EGPA. Because of the risk of serious long-term adverse effects, maintenance oral corticosteroids should be considered only as a last resort in any age group. If other treatments have been optimized and still no alternative is available, the patient remains uncontrolled or partially controlled. Also, written asthma action plans have been stressed upon. These written plans can be printed, can be digital, or they can be pictorial. They should be given to patients with instructions about how to change their reliever and controller medications when their asthma worsens before consulting their physician, and when to seek medical advice rather than giving only verbal instructions to these patients. In children less than equal to 5 years with intermittent viral wheezing and no or few interval respiratory symptoms, intermittent short course inhaled corticosteroids should be used provided the physician is confident that it will be used appropriately and compliance will be good. Several emergency department studies of formoterol and one study budesonide formoterol have shown the safety and efficacy of ICS formoterol is almost similar to that of salbutamol for management of acute exacerbations in healthcare settings. But this still has to be taken with a pinch of salt because more studies are needed before a final recommendation is made by GINA. Air filters can reduce fine particle exposure, but there is no consistent effect on asthma outcomes. Electronic inhaler monitoring can identify poor adherence in patients with difficult to treat asthma and in patients with uncontrolled symptoms despite medium to high dose inhaled corticosteroids containing treatment. Higher blood eosinophils and higher fractional excretion of nitric oxide are associated with a poorer prognosis and a greater risk of severe exacerbations. Now a word about the COVID-19 and asthma, which GINA 2022 has mentioned, and it says that patients with well-controlled mild to moderate asthma are not at increased risk of severe COVID-19, but the risk is higher in patients who are taking oral corticosteroids for the asthma or in hospitalized patients with severe asthma. Regards aerosol generating procedures, GINA 2022 says that use of an inline filter minimizes the risk of transmission during spirometry, but precautions are still needed since many patients cough after performing spirometry. Annual influenza vaccination should be done, and the use of masks is indispensable in areas with high risk of transmission of COVID-19. Thank you so much for a patient watching and listening, and please do share the knowledge. Thanks a lot.